Good afternoon. Oh, good morning, everyone, I think. Yeah. Yes, I'm pleased to introduce Dr. Andrei Kushniruk to give us the first seminar of the season or this term. So Andrei is not strange to us. So his his background is a perfect recipe for health informatics. He's got a biology and psychology as a degree. He's got a master in computer science, and then he's got a PhD in a cognitive psychology from McGill. So he's a perfect sort of embodiment of the health informatics, if you like, for us. So he, in the past few years, he's conducted an enormous amount of research, and in his field of human-computer interactions and evaluations. And he's got an enviable number of the publications, which I don't even reach half of it yet. So it's about over 300. I think is going. So his scholarly work is known nationally and internationally. I think possibly more internationally. So I'm very pleased to have him to start this seminar series for us. The title is The Human Factor of AI in Healthcare. Where are we now and where are we going? Here we go, Andrea. Floor is yours.
Thank you. Yeah, what I want to talk about today is the relation of human factors and AI. I've worked in both fields, as I'll discuss. And towards the end of the talk today, I want to show some new developments we have with some new technologies we've acquired at the school around these areas. But human factors and AI, my first point, have had a very long and intertwined history. My thesis has always been, even since the 1990s, was that the success or failure of AI applications in healthcare is really closely related to the usability of the systems and how well they fit with workflow. That was true back then, and it's still true today. I also want to show that there are methods available for increasing the success of AI in healthcare for adoption, for usability, and for safety. But these have to be based on the consideration of how best to integrate the AI technology with humans. So let's go back. I always like to begin by starting about discussing human factors. What is human factors? Well, human factors is a scientific discipline concerned with understanding the interactions among humans and other elements of a system. We can replace systems with technologies, devices, people, organizations, and this could include AI systems. So it's a rather broad definition. If we look at the subfield, because human factors existed a long time ago, even before personal computing or computing. Human-computer interaction, the acronym HCI, I use a lot, is really a subfield of human factors dealing with the interactive computing devices for human use, and I write the quote there, the study of major phenomena surrounding them. So it's very broad as well. So we'll get into areas that have to do with psychology, sociology, and that definition, my favorite, was from the Association of Computing Machinery. Just some background. I've worked in the human factors of healthcare for many years and often wondered, why is it so hard in healthcare to come up with easy-to-use systems and integrated systems? Well, and I have worked in other areas. I've worked in, I'll mention, well, back when I worked in AI and transportation, I worked in AI in nuclear systems, but nothing matched the complexity of doing systems, AI, or even electronic health records as in healthcare. Why is this? Well, healthcare is complex. There's a lot of uncertainty, ambiguous information. From a cognitive point of view, we can say that many of the problems are what we call ill-structured. They're not a clear solution. We have local needs and variations depending on where you are, what hospital, what country. And we have extremely varied types of users. Before we had what Piper Barker immersed, now we also have patients and lay people using systems. I'll talk a lot about workflow, one of the key factors here, and the whole idea of integrating anything new into a complex digital health ecosystem, whether it's electronic health records, patient portals, or AI. So I look at AI in a sense as similar, different technology, but similar that we want to place it in healthcare. And I would say that all the above makes healthcare arguably the most challenging area and most interesting for implementing any advanced technology, let alone AI. So just looking back at what happened in AI, I'll take a bit of a historical perspective in a minute. Well, one thing is AI is many technologies, and it's an area that's been researched at universities for 40, 50 years and longer. And one of the earliest areas was actually in healthcare. And there have been a lot of advances in the past 40 plus years that have improved the quality and safety of patient care. Most notably, there's been a really resurgence, because I'll talk about how far this goes back, the work with artificial neural nets and deep learning systems. The work on that began a long time ago. Earlier in my career, I worked in the lab at the University of Toronto, where that work was just brought to Canada by Jeffrey Hinton, who just recently got a Nobel Prize in physics, of all things, because of what he was doing. I worked there. I didn't work on neural nets. I'll talk about that. I think I was doing the wrong side of it. I was working on knowledge-based systems, but that goes back to that long ago, and that work just continued and really took off post-2000. Machine learning and data mining, natural language processing, speech recognition, the list goes on, predictive analytics, even I would argue that intelligent bedside monitoring, analyzing waveforms in real time and triggering alerts is a form of AI. Automated image processing, we wouldn't have big data analytics, bioinformatics, or genomics without AI. So it's there now. And there are lots of beneficial examples already. In radiology, and we talk a lot with radiologists, the automated analysis of imaging, pre-processing PET scans and other images to locate where there might be a problem as a form of decision support, highlight it for a physician. Dermatology, I'll give an example today of a project I've worked on in that area, a lot of different potential applications for decision support, alerting, triaging about when a lesion might be cancerous. Pathology, again, image processing, collection, cardiology, diagnosing cardiology problems, and predictive analytics, systems that might predict that there may be a cardiac event coming up. Psychiatry and psychology, the idea of chatbots for automated consultations and alerting applications that might alert health professionals that someone is trending to, say, depression. Robotic surgery is one of my favorite. This is really advanced in the US, and it's not an example of an autonomous AI. It's robotic systems that have a really excellent maps between what the human does and what the system does. And some of you may be familiar with my favorite system. We don't have it here on the island, called the Da Vinci surgical robot. Pharmacy has the potential for automating routine tasks like dispensing. Documentation, there's been a push recently, I think very good, on applying AI for reducing clinician burden and checking reports. And education, intelligent tutoring systems, and last but not least, just informational resources, for example, chatbots for providers and patients with generative AI. So I divided, looking back at what the current classes are of AI, into 3 categories, and I'll talk about this. One category that was kind of most developed up until the breakthrough with the generative AI, we could call discriminative AI. And that would be AI that could use neural nets, for example, to discriminate between cancerous moles or non-cancerous, classification of, for example, images, or differentiating amongst possible diseases based on symptoms. Another category we could say is predictive AI, all the work done on trying to predict flow through a hospital, some examples, predicting clinical outcomes or cardiac events. And last but not least, in the last 2 years, we all know about ChatGPT and the potential for generative AI to generate reports automatically, summarize doctor-patient interactions, and also for patient-patient chatbots. Whoops. So yeah, I wanted to just talk about where we got, but what are the characteristics we're most interested of successful AI today? Well, AI is being shown, as I said, to excel at well-defined tasks, particularly the neural net applications. Less so with ill-defined clinical tasks that involve complex reasoning or planning. Even the neural net gurus say that they haven't cracked how to get those systems to deal with planning complex activities. But there is high accuracy reported, for example, I'll talk about today, in identifying from an image if a mole is malignant or not, or identification of a tumor from a scan image. Second point, and I keep coming back to this one, AI has been most successful when attempting to support, not intending to replace human in the loop, unless it was such an autonomous thing it ran in the background and we didn't need to see it. AI has a lot of potential for supporting poorly resourced activities and services, for example, AI chatbots, and we will see that AI models will have to be adaptable and flexible. Now, one of the things I always like to do every year is update my presentation with a Gartner hype cycle chart. I don't know if you're all familiar with the Gartner hype cycle chart, but I will just walk you through. Gartner, the consulting group, does this for many different types of technologies and innovations. It's the idea that there's a cycle, actually, of expectations and hype when any new technology comes in. If we read this graph on the left-hand side, you start with an innovation trigger. A new technology is introduced. Generally, there's a lot of expectations that go up and up and up about that technology. It's going to do everything, solve everything, until we get to what they call the peak of the inflated expectations. Invariably, as reality sets in, there's usually a drop, and then we get into called the trough of disillusionment. If the technology isn't useful, it fades away. However, really good technologies kind of build back up onto the plateau of productivity. And on the chart right now, so for example, I don't know if you can see my cursor, on the far right, computer vision went through a whole cycle, overhype, reality, and now it's in practical use. A lot of natural language processing for restricted domains is in practical use. However, there are some that are on their way up. I won't talk about artificial general intelligence. It's a misnomer. The people talking about it haven't even defined what they mean by intelligence. But at the top, it's interesting to note, they did locate generative AI. So it may be kind of peaking in terms of what it could do. And I've seen that in healthcare because a lot of hospital research groups are now trying to apply it, and it's not as easy to integrate into the healthcare practice as we thought. It will probably go down and then back up because there's a lot of value in it. But this is very interesting. As I say, look up Gartner, the hype cycle. They keep revising this every year. Okay, as I said earlier, a bit historically, AI isn't new in medicine and healthcare. Some of the earliest systems, like Ted Sortle's MySim system, date back to the 1970s. I got into this prior to 1990. Not in healthcare. I worked for Canadian Pacific Railroad doing AI systems. I then got in with the top AI lab at the time in Toronto, doing research in object-oriented, rule-based combined, what we call second-generation expert systems. However, and as I said, too, that was a lab that really was an incubator for a lot of the neural network research that went on that took off 20, 30 years later, although I didn't work in that space. But the thing that happened towards the end of the 1990s, which was career-changing for me, was that every medical school and university developed what were known as expert system AI, and they all ended up becoming prototypes or pilots. Not one of them actually ended up in practice, which is what they were supposed to do. And being in the field, I thought, well, do I have a future? So I ran across a paper in a 1990 paper that was written by two of the people that had developed a very famous system called Internist. By 1990, they were giving lectures about why it didn't work, why people didn't want to use it. So they were famous developing it and then became famous for talking about what was wrong with it. Good career. So in that one, they wrote a two-page article called The Demise of the Greek Oracle Model for Medical Decision-Making. And if you know about those systems, the doctor would sit there, transfer the information to the computer, and the computer was like the Greek oracle, telling them what the diagnosis was or treatment. And that really wasn't acceptable to the doctors. The argument was that the doctors didn't want the decision replaced, they wanted support, and that physicians needed a catalyst to help solve their own problem. Well, at the time, I thought, well, therefore, the issue must be human factors. In order to support human cognitive processes, don't we need to understand and have ways to map those processes out to see where we can insert the help? And later on, I'll talk about journey mapping and the work we did with dermatology. But as I said, that greatly influenced my career plans, and I took off from AI. I dropped it and went into studying human factors in healthcare. So I have a reference for a paper at the end of this, but having been in the AI field then and tracking it since, I did a paper on what the issues were, a chapter in the two books, on what were the human factors issues with AI back then, and what are they now, and are they still there? Now, I'm not saying the technology is the same. It has improved incredibly. It's much more effective. And some of those methods, like neural nets, when graphical processing units came about, really took off. However, in looking back at what I remember then and now, the general categories of issues are often the same. Currently, we have issues of trust, accuracy, and legal liability. What if the AI makes a mistake? Recently, 2018, I was at a workshop in California where hospital managers were there, and I know there are more FDA-approved neural net applications now, but at the time, we were under 100. So managers were saying, if I include that in my hospital, what's my legal liability? What if it makes a mistake? We can get into other thought experiments. The other one is about autonomous self-driving cars. Everyone said it will make things safer. We will never know until they're on the road, even no matter how many simulations we do. And will it make it safer or not? We don't know that, but I remember from back then, if you compare a human to an AI system, the mistakes are different. So then we get into a discussion, is the AI mistake worse than the human? And we can get into that, but there's a whole field in human factors called failure modes, which needs more exploration currently. Knowledge acquisition was called a bottleneck back then. Back then, the expert systems ran by rules that were put into a knowledge base. So the question was, how do we get the expert knowledge in the system? Fast forward to today, and there's a lot of issues about data training sets. Where do we get the data sets from? Is there bias in the set? Is it generalizable? So again, a different technology, same issue. Another one that is recurrent issue is human understandability of explanation. Is there an explanation capability? If you want to engender trust, the system should be able to explain why it decided something. So back then, it was simpler. If you asked Mycin, for example, how it decided on a diagnosis, it would show you what rules it used. Fast forward to today, and this is a very hard nut to crack. With neural nets, you can't just ask it how it came up with a decision. It's like a pattern of activations of thousands of millions of nodes. So there's whole conferences on that now trying to figure that out. I don't think they have. The need for effective HCI interaction modes, how embedded or ubiquitous is the application? How much is handled by the human versus the system is another major issue we had then, we had now. They didn't like the systems where it took their locus of control away, like Mycin, the ones I talked about historically, and we still will have that issue with systems today. This one is a good one. This never goes away. Challenges of integrating with existing software systems and work processes. Another one, issues around generalization. Earlier with AI systems, there would be often excellent results reported from a particular hospital in a particular country that then were not replicated elsewhere, and we've hit this as well. This is where the last point, where I think that term AGI, artificial general intelligence, people are throwing around. When will we have it? Is it coming next year? You know, Elon Musk and all of them have on TV, and they never even define what they're talking about. I had this bullet from before, but my point about this, for some applications, mainly what's known as common sense reasoning, planning ability, and perhaps going to a knowledge base of world knowledge outside of the scope of the application to supplement the reasoning at a deeper level when required. So the question is, when do we switch out from the system to the human and vice versa? Elizabeth's done a lot on this, the need for risk and safety evaluation. And I would say testing under real-world conditions. And it's fair to say that naturalistic evaluation of AI has been lacking. And I can say this from experience with systems. I was once asked to work on IBM Watson Oncology. That was 2017. And I said, did you not already have evaluations? And they did, but the evaluations were focused on, was the output the same as or better than the doctor? They haven't at that point, which was shocking to me, done evaluations of how to integrate IBM Watson Oncology on rounds in the hospital or with physicians. So another area, understanding failure modes I mentioned, the interoperability of the systems and integration into practice and workflow. So, not to be all negative, I like to think about solutions. And I have been working on AI. And so I've kind of looked at this concept of AI in a sense as a framework that can be used for evaluating and understanding AI applications through a usability lens. And through this lens, as some of you know, this is my favorite definition of usability, as a measure of a number of dimensions. We could do studies looking at learnability. Is it easy to use, to learn how to use or not? What about training? Often there's not. And we've applied all these dimensions for everything, hundreds of studies for electronic records, decision support, and also AI as another application area. Effectiveness, is the system effective or not? So some of those evaluations I mentioned, like IBM did with IBM Watson, focused on effectiveness, but not efficiency. How does it fit in? Satisfaction of the end user. And last but not least, safety. So I will argue that all of the above are essential for AI success. So if we're building out an evaluation framework for AI, we can use this just as we would apply it for any other technology that's new. As you know, many I've done work a lot. Once I got into human factors, I worked on packaging usability testing so that it could be done anywhere at low cost. Things have gotten easier because technology has gotten better. You can do usability testing in any setting with free software, recording screens, recording interactions. We can record workflow. That example there is just myself doing the simplest case, thinking aloud while using a personal health record and alerts that come into the record. And we may or may not have external views. We've extended this over the years into what we call clinical simulations, because when we go into the simulated or real environment, we take the equipment there. So there are all methods, as I mentioned, that have been underutilized with AI in natural settings by testing in real or context or in situ, we call it. Bottom there was an example of a project we did where we started working this way in a hospital in Japan, where we looked at interfacing the technology in a clinical room and also what they were using when they went to the computer on the trolley, what they were actually doing on the computer. We're able to optimize the process. The other advantage of this, it allows you to have a view into the workflow processes. So in general, we can have a continuum of how these human factor studies can be applied. From the far left, the laboratory style that's more artificial, although I would say this doesn't require $1 million usability laboratory. We could do it in someone's office, but it's still laboratory or artificial. Clinical simulations, that's a simulation room in the middle, in the hospital where they were testing out. That example wasn't AI, it was electronic health system procurement in Denmark. And we can also wire things up to collect data in the real or naturalistic setting. And this framework we've developed has been useful for evaluating many types of systems, including AI. I'll explain that when dealing with evaluating systems, we like to constrain the complexity by starting in the layered approach and beginning with looking at users interacting with the system in isolation. Using, for example, the very simple usability testing methods I just showed on that slide. If we can optimize that, we can then move up and test out the system in the clinical environment using what I referred to on the previous slide as clinical simulation. So they get you different things. The usability testing at level 1 will get you surface usability problems. And those will end up destroying the usability of any system, whether it's electronic records or AI. If we can't turn it on, it's not going to be used. We can fix that. However, once we go up to level 2, it gets more complex. How does it affect the workflow? Will it be adopted by the doctors or nurses? And then last but not least, a third layer that opens up more because less unconstrained is the level of multiple users interacting with each other in organization. And there we move from simulations into other areas that mostly I've worked in the level 1, 2. But if there's a project where there's a problem, I've usually started but with one, optimized the system, and then moved up. So logical progression. And we have done this, as I will show, with AI examples. Oh, okay, I have an example on the next slide. This was one I reported on about 2 years ago, but since did further analysis on. It was a project on AI dermatology point of care. It was a supercluster project in BC, which was an industry, hospital, university collaboration to help improve care for skin cancer. So the objective was, our objective, the technology was developed. So it was developed by a company that had developed a very accurate system. So we weren't called in to develop the system. It was a neural net application, like many others. We were called in to effectively integrate the AI-based imaging system into a regional healthcare system as part of this Canada Digital Supercluster project. So the technology, as I said, was there from the company to arrive at a highly accurate identification of potential melanoma greater than 90% accuracy. But the bigger problem is, how can this technology be integrated into practices of primary care physicians across, and specialists across the health authority, and into technology that already exists? So technical, I just want to say in Canada, Elizabeth and I were looking at stats yesterday. The stats for wait time lists are horrendous. By the time we get a surgery, if you have a cancer, we've probably moved on a few stages. This is something else I'm going to be writing about. It's just shocking. Patients may wait months to see a specialist. If the GP, general practitioner, sends you to the dermatologist to have a mold check, everyday waiting could lead to progression of cancer if you have it. And I'll talk about stats. The average time from the family doctor to the specialist in BC when we started the project was 192 days. And if something that could be taken out in size for $2,000 would cost $200,000, or they wouldn't even give you the operation, the palliative. So what did the solution do? The idea was that the picture would be taken in the GP's office. The GPs had the device from the company, and they also had something called the dermatoscope, the patch proof, $800. Train them to do good images, because the data depends on how good the images are. Although I know researchers in Taiwan that are trying to get patients to do it from home, but the image quality is variable. I don't know how that went. So it's taken by the general practitioner or family doctor in the office. Once the picture is taken, it's almost near immediate analysis by AI image software with high accuracy from the cloud. It sends the pictures up, and then it compares them to a set of labeled pictures of images of cancer or non-cancer, the ones that are closest to the one that the physician took. So it's very careful. They're careful not to step on the toes of the doctor. That doesn't say they have cancer. It just says, here's an image. It's ranked very high for cancer, and it's 98% overlap with your patient. So that's what's come down as a report, and with some probabilities. So then, if it's high, that family doctor can hit a button and immediately send the report to a dermatologist electronically. So the study design was to evaluate the solution and also work on its integration to get the AI into production. And after we did this project, I didn't know what happened with it, but we were at a conference for PHSA, and Providence Healthcare was there, and they were talking about the great innovation. It was this project that continued. Often when we're doing these projects, we don't know what happened to them. So it was really nice to know it went into real use. The method, we wanted to analyze where to target the AI in the patient journey. I'll talk about journey mapping in a minute. From the point of the very beginning to the GP, the dermatologist, where will we get the bang for the buck by implementing this? We conducted usability Zoom sessions with individuals, GPs, specialists, and patients, using Zoom to do video analysis recording. They were video recorded, they interacted with the application, and also interviews. So the data was our usual audio and video files. So this is where I want to show a lot can be done with the method called journey mapping. So this was two journey maps here. One was before the AI was implemented, where we mapped out the whole consortia of what happens. Well, primary care exam at the top, then refer to a specialist if there's a problem, potential problem, we don't know, wait. The specialist sees it. It may then lead to a biopsy, waiting for results, confirming count, etc. So that part from the primary care exam to getting a biopsy could take up to 6 months, which is very good if you have cancer. After implementing the system, the implementation of it, the insertion point was in yellow, AI engine assessment. The primary care exam, then they used the system, and if they needed a biopsy, how long did that take? For 84% of the time, it took 5 days or less. So it had reduced 6 months to 5 days or less. And when we did a graph of how long it took, on the graph, some of them said 0, because we didn't know it was the same day. So the doctor hit the button, the dermatologist is more likely to respond. Now, there was one problem with this evaluation, you could say. We weren't able to separate what was a positive impact from the AI versus the telehealth. So that one still leaves it open. I think it was a combined synergistic effect that it got sent, but it had the information. So as I mentioned before, the wait time from GP, the specialist, was 192 days. Now, most of the referrals were 5 days or less, with some triggered the same day, reducing unnecessary transfer times and costs. The qualitative findings, physicians, when we interviewed them, said that it was usable and useful. Well, I didn't have one in there, which is a real killer for a lot of projects. I remember now that they asked, can I bill for this? We won't get a system implemented unless they can bill for their time. So somehow Providence figured that out, or the province. I remember that. I should have put that point down. It's one of the ones that stops up projects a lot. They wanted the solution to be integrated with a range of electronic medical records. Now that's interesting, because I said the integration issue was one with AI back then and still today. Because when we started the project, it was going to be integrated with an electronic health record vendor. The vendor pulled out, and then now it's still standalone. So you have to use it and then use the system. Data won't necessarily transfer. But it did identify a significant decrease in wait times substantially. Patients we interviewed, and they said they liked that the doctor used it, and because they knew they used it, because the doctor used it on them. Viewed it as an improvement in care, and it added confidence to their care, eliminating unnecessary stress waiting for a long wait for diagnosis. So the intent was not to replace human diagnosis, but to flag potential cancers, speed up timely treatment that otherwise could take months. So good example of a life-saving application given wait times. However, the integration is needed in the whole healthcare system, and this is still a challenge. As I said, there was only one health organization adopted it. Our plans were to have the whole province, but it's hit the roadblocks. So there's need for further human factors analysis and studies to target where the target AI for integration success, using, for example, journey mapping. So I switch gears a bit. I want to talk about where we've gone now, and some of you I know are graduates of our program, and we've been lucky enough to get an influx, which we never got before, of money for buying all kinds of interesting technologies. So we bought them now, and now we're figuring out how to use many of them, robots and others. But we have set up several labs. On the far left is Dr. Busari is there providing treatment for me. Dr. Baricki. Anyways, what we're doing there is setting up simulated rooms where we can bring in technologies, not just AI, but others, and look at how they can be integrated. With the room we're in now, we have plans to make this also double as a hospital command and control room, which we haven't done yet, but we will. And on the far right, some of you are seeing our smart home lab that is set up as someone's house with an array of different types of sensors built in, fall detectors, motion detectors, pressure detectors, smart television, many others. And I'll explain how AI will be fitting in that in a moment. That's the actual smart home. It looks like a nice apartment down the hall, but it's all wired up. So anyone wants to see it, come to Victoria, I'll demo it. We had before set up a plan for where different devices would be included in the layout for the smart home environment, including sensors. So possible, these are possible. This is ongoing uses of AI technology in the smart home we're exploring. Speech recognition and natural language processing for commands. For example, an elderly person could ask to turn the light off. We saw use cases of disabled people. Perhaps they can't move their arms using speech to activate a shower. So we are putting in, I think, Google Nest and others. Context sensitive for help around the home, and I'll talk about some robots that can be used in the home. This is where we can look at other things like automated analysis of interaction with devices, cooking, plumbing, sleep patterns. And I will say with this one, is it doesn't require rocket science. We can do complex analyses of sleeping patterns with the sensor data we have, but in a lot of cases, alerts and reminders based on simple parameters like an elderly person that their parent who lives in another city hasn't turned on the water faucet or used the plumbing, will send an alert to the caregiver. So there's a lot of potential, but we can also get into more complex analysis of the logs of patterns within the house. Automated alerting and reminding about both unhealthy and healthy patterns, like did they take their pills, can appear on the television, and alerting about dangerous situations. But we will be using patient journey mapping. Again, I mentioned from the dermatology project that was so useful to find out where and when to best to integrate and trigger AI support. So here are some recent additions to the lab. We actually bought them. There's the now. Oh yeah, and two of our co-op students in the summer, Harisha Kesh and Rick worked on doing some work on how they can be integrated, where they have been integrated in healthcare, and I'll talk about that in a moment. The now robot is, the smaller one's quite autonomous. I've seen videos of two teams of now playing soccer autonomously, although they were very slow, but it's more mobile. The other one that's bigger in the middle is Pepper, but what you can do is integrate into them things like ChatGPT, generative AI, with just be working on starting to do that now. We can interface with Python. And on the right, Pepper being used in a hospital. So this is from our summer review, just some notes I made of what we were finding of how those particular robots, since we'll be working with them, what use cases in healthcare. Another area you can look at, what are successful use cases of AI or robotics and AI are related, obviously. Well, one is building relationships, you saw on the previous slide, with hospitalized children. They seem to like it. And it's a technical distraction during a hospitalization and waiting room. And now it can be used for elder care and help with things like depressive order. I'll show one on the next slide. Pero robotic seal, which is a therapeutic seal. Humber Hospital years ago was using Pepper for wayfinding at the front door. Informational support integrating with generative AI. We're so short-staffed, the nurses and people that can monitor patients in their rooms. So it could be a patient companion that could alert the front desk if there's a problem. Not perfect, but better than not having anything. Interviewing patients in waiting room and hospitals. Not anything we were working with, but I had seen some great examples of robotic mechanical systems that could assist nurses with lifting patients out of bed in Denmark. So this was work, kind of expensive work done with Elizabeth Bricky and a group of others. We were working initially on emotive interfaces. How can questionnaires be developed to be more user-friendly and children could use them and they would have empathy, how the system would have empathy. We're looking at how we can characterize what factors or features of robot design lead to this realistic feeling that you're interacting with not with an inanimate but an animate object. If you come to the name office, Pero, we call it, Pero is a brand name from Japan. We call this ours Miso. Is amazing. Once you turn Miso on, it personalizes to you, it looks at you, and interacts with you through engagement, tactile response. So we're looking at what are the aspects that work. How can we decompose what design features work? This is a very expensive therapeutic robot, there's cheaper ones, but we wanted to start with one that really works amazingly well and then understand what are the features that make it work, because then we can work backwards to design systems. So if we ever stop by, this robot was a real hit. Integrating AI solutions, could do focus groups and interviews, but the idea is what are the use cases for AI? Again, back to my theme of where and how to insert. What mode does the AI do? Is it consulting? Do we consult it like Myson or IBM Watson? Does the system critique? You have a treatment plan. Will the system critique it? Is it augmenting human perception or skill? I could do a whole lecture on the Da Vinci robot. It's just fascinating. It's really adopted highly in the US for non-invasive surgery, where the physician works from a booth controlling a robot. So it's not autonomous, it works with the human. Expanding physical access, or does the AI run completely in the background and you won't even know it's there unless it fails? Alerting and reminding, I would say all the work in AI, not all, but much of it, that even didn't become mainstream. For example, the rule-based expert systems from the 70s and 80s became the direct foundation for the rule of alerts and reminders that are triggered that you use daily in Surma and Epic. And so it didn't end up the way it was overhyped, but it ended up on the plateau of productivity. A lot of people don't realize that and just say, oh, it didn't work. Machine learning, are you doing that? Generating text or images, or is it advising system? This is from a paper, Bricky and colleagues. Just an example of what was interesting paper they did on how to integrate applications into the patient journey. So if you look at a particular disease or issue from the spot on the left-hand side, a patient has symptoms, questions, going to get a diagnosis, getting treatment in the hospital and post-recovery. The approach of mapping that out is very useful, and then asking at each step. I think what they did was ask, what technologies have been used to support that step. And often you'll find that there are many gaps in here where we can use this to, like we did in the Durham project, look for the area of most impact. So another area we worked a lot on, and we have a special issue on this, several patient journey mapping. So lessons learned from integrating AI solutions. Well, back to the beginning of my talk, must be inserted for a task is proven to be good at doing, otherwise no point. Must be accurate, but accuracy alone won't get adoption. It has to be accurate. And then we decide on what's accurate, what percent can you have or not. Must be useful for something, better patient care, save times, better organizational outcomes. If it's not going to create something, if it's not needed and the original way of doing something is working, why do we need to add it? You have to ask those hard questions. And what are the implications? As I mentioned, health managers will ask, I can do it, but do I have legal liability? What happens? Where else is using it? How it affects must consider my argument, work practices, workflow. I won't get into it here, but how it affects reasoning processes and ultimate decision-making for human and machine decision-making together. We believe patient journey mapping is useful and must be safe. A lot of problems are with testing that didn't test systems for rare or extreme conditions. I mentioned not testing and under naturalistic conditions, not testing for usability, usefulness, or workflow integration will lead to systems that probably won't be integrated. These are rules that apply not only to AI, but many other systems. I think when people become enamored with the technology, they often forget about this, that we have to look at these issues. And at the bottom, I said, need for testing in new environments, in situ naturalistic testing. And implementation, if you deploy underperforming system or can adapt, this won't fly. Another topic we didn't get into is issues of security and privacy. Could do a whole lecture on that. And failure to explain to users how the technology works. In some cases, why the technology is being implemented at all. Its benefits, limitations, and safety issues. So this was a slide from a yearbook article we did, Brickable. I'm looking at saying if you want to make sure AI works, you have to go through a sequence of phases. And we've had people in AI saying, well, I don't like that because that would take some time. We're AI, we do things quickly. Well, in healthcare, if you do things quickly, they won't get adopted. And we get into the issue of a lot of hospitals will say, not only should we be doing usability testing, usability inspection, naturalistic, what about your clinical trials, other technology, which are not, there are ways of speeding that up, but that's an assurance to an organization that they're not implementing something that may be dangerous or liable. So key points to remember, human factors are critical to AI implementation success. That applied in the history of AI, both during those upturns and downturns. Apparently, we have had more than one AI winter. I hit the one in 1990, but I think there were two other ones. So, and I have had questions like, are we going to get another one? I remember asking that to a very famous professor about 2 years ago, and he was promoting AI, and he just said, I don't like your question. But having lived through it, I felt that I could ask it. AI has the power, and there's no answer. Power to enhance and improve patient outcomes. Attention must be given to how and where the AI is implemented if you want success at all. And important to work with future users of AI and designers to identify and test integration points in the digital health ecosystem. And as a positive note, I would say methods and tools exist that need to be used more to support AI testing and integration prior to implementation in real-world settings. And that's it. I'm just putting a plug for a book that I edited with David Kaufman, Thomas Campanella, and Vilma Patel. The new edition's coming out. It's modern AI, human-computer interaction in healthcare, the role of cognition, but we updated it because of AI with a number of chapters on what does cognition have to do, human cognition have to do with AI. Thank you.
Great, thanks, Andre.
Thanks. Amy,